Good morning. Good morning, everyone. Welcome to the American Academy of Actuaries Health Equity Symposium, and thank you for joining us here in person in DC, but also everyone online joining us virtually. I am Bill Michelson. I am the Executive Director of the American Academy of Actuaries. The Academy is an almost 20,000 member professional association whose mission is to serve the public and the U.S. actuarial profession. For almost 60 years, the Academy has assisted public policymakers on all levels by providing leadership, objective expertise and analysis, and actuarial advice on risk and financial security issues. In support of our mission to serve the public, today the Academy is bringing together thought leaders from diverse stakeholders in an interactive symposium format to address an issue of significant importance, namely health equity. We strongly encourage participants to add their helpful perspective both in the room and online, and look forward to having a robust dialogue over the course of our time here together today. This symposium is the culminating event of a series of virtual workshops and conversations held throughout this past year. Those workshops were aimed at exploring how health insurance design benefits are made and potential strategies for employers and insurers to incorporate more equity-enhancing benefit design elements. Thank you to everyone who participated in those workshops. I'd like to also take a moment to thank our sponsor for today, Arnold Ventures, for their support. We greatly appreciate it. Included in your materials today is a QR code where you can access the 4 issue briefs that were created based on the conversations from those virtual workshops. They are also available on the Academy's website. You can access that via actuary.org. I hope you all enjoy today's event and take the time to share your knowledge and engage in the dialogue and share those perspectives on this most important issue of health equity. In just a few moments, you'll hear from the architect of today's symposium, Annette James, Chairperson of the Academy's Health Equity Committee and a member of the Academy's Board of Directors. Before Annette speaks, I would like to hand it over to Jennifer Alexander, our facilitator for today's symposium and moderator of those 4 health equity workshops. Jennifer will cover a few housekeeping items and keep us all honest for today. Jennifer is a public health researcher whose experience includes 25 years as a professional focus group moderator, interviewer, and facilitator and trainer. In her day job, Jennifer leads tobacco regulatory science for the FDA. Please join me in welcoming Jennifer.
Thanks so much. I'm gonna lower this a little bit. Hello, everybody. It's great to see you. Thanks for joining us. So before we get started with today's symposium, I need to go through a few housekeeping items so all in attendance can understand the Academy's expectations for the event. It's the policy of the Academy, and it is the responsibility of every symposium participant to comply in all respects with federal and state antitrust laws. No activity or discussion at this symposium may be engaged in for the purpose of bringing about any understanding or agreement among symposium participants to 1, raise, lower, or stabilize prices, 2, allocate markets, and 3, encourage boycotts, or in any way violate federal or state antitrust laws. Professional associations like the Academy, by their very nature, must be particularly sensitive to avoiding antitrust violations. This is because, in bringing competitors together for a symposium like this, one element of a possible antitrust violation may already be present, a combination of competitors. Thus, all that may be needed to create an antitrust violation allegation is an inference that there was an action to restrain trade. Symposium participants should refrain from any discussion that could provide a basis for an inference that the members agreed to take on any action that might restrain trade. For more information, please see the Academy's antitrust policy on the Academy's website. Okay, so we're here today because of the hard work of the Academy's Health Equity Committee. The Academy formed the committee to further the actuarial profession's commitment to health equity through the healthcare system. The committee examines actuarial practices and methods to assess the extent to which they may affect health disparities and recommends changes when appropriate, identifies areas in which actuarial methods can contribute to improving health equity, educates actuaries and other stakeholders on health equity issues, and applies an equity lens to the Academy's health policy work. That work led to the publishing of numerous discussion briefs, including an overview on health equity from an actuarial perspective, and more detailed exploration of issues related to health insurance benefit design, premium pricing, provider contracting and network development, and population health management. More recently, and as you heard, the committee released 4 issue briefs examining different elements and perspectives of health equity, crafted with input from a spectrum of stakeholders representing different facets of the healthcare ecosystem, including employers, actuaries, and providers. The plan today is to build off of those documents and use this open forum to speak at length and in depth about the state of health equity and where to go from here. For now, I'll hand things off to Annette James, Chairperson of the Health Equity Committee, who will delve further into the topic. Thank you.
Good morning, everybody. Okay, let's try that again. Good morning, everybody.
Good morning.
That's better. Okay. Oh, thank you, Jennifer, for that introduction. And apparently, I was going to say I'm a health actuary, but apparently I'm an architect also. So thank you all for being here in person and also virtually. This is a really important conversation. I am Annette James, as I said, and, I would like to, first, before I start my comments, I would like to thank the team that is responsible for this entire event. It's volunteers as well as Academy staff, and they've worked tirelessly to make this event a reality. And I also want to thank all the panelists that are going to be part of this presentation today, and also everyone who's here. I thank you so very much. This is a really important conversation. So today's event is the culmination of a 4-month long conversation, or rather a series of conversations on equity enhancing benefit design. And it's really a testament to what we can do when we all work together. More on that later. First, I would like to give credit to the leadership of the American Academy of Actuaries for having the courage to make equity a priority in our public policy work in all practice areas, not just health. And so thank you, Bill, for your leadership and your support. The focus on equity is our public policy work. It's just one manifestation of the Academy's commitment to infuse principles of diversity, equity, and inclusion in everything that we do. We recognize that addressing health equity is not just the right thing to do. It's not just a moral imperative, it's also a business and economic imperative. The fact is that disparities in healthcare affect us all, showing up in lower life expectancy and higher incidence of chronic conditions among historically marginalized populations. It is also an inefficient allocation of healthcare dollars. A 2018 study estimated that disparities in healthcare cost approximately $135 billion, that's billion with a B, every year. That's $93 billion in excess medical costs and $42 billion in lost or untapped productivity per year. The US has the most expensive healthcare system in the world, and yet not everybody gets the same quality care. Addressing health disparities and health inequity will not only improve the lives of individuals, but it will also enhance our collective footprint in the global economy. Health equity is about giving people what they need so they can attain the best health outcomes possible. That means that some people may need more, and some people may need something different to get the best possible healthcare outcomes. We need to understand what people need and fill those needs, knowing that they will be different for different individuals and different communities. This requires not just individual efforts, but also systemic and structural changes in the policies, procedures, laws, and individual and professional practices. And these practices, laws, and systems have supported the inequitable healthcare system that we have today. That's a fact. So to do that will take leadership and commitment from each of us. The fact is that people have been underserved and marginalized because of their race, gender, age, socioeconomic status, religion, where they live, sexual orientation, disability, and other characteristics that are important to who we are. Health inequity means that some people live in areas with few or no primary care providers or healthcare facilities, what we call healthcare deserts, or they face other barriers to accessing care. For instance, the hourly worker who can't take time off for a doctor's appointment during the weekday, or doesn't have access to a physician who speaks her language, or doesn't have a way to get to the doctor's office, or all of the above. Health inequity means that out-of-pocket costs are preventing people from getting needed medicines or other treatments. It means that even if certain tests are free, if the follow-up care isn't, then what's the point? So preventive care or even needed care is deferred. So because of that, preventive care or needed care is deferred, leading to worse health outcomes. We want to achieve health equity for everyone. We want everyone to achieve the best health possible. But we can't do it alone. We must work together. And who does that mean? It means policymakers, doctors, nurses, other healthcare providers, employers, community leaders, researchers, insurance company regulators, actuaries. Yes, all of us. It will take all of us working in partnership to achieve the goal of health equity. Knowing that health inequity is a complex problem with many interconnected parts, and it's difficult to solve, is not an excuse to sit by the sidelines. We need to get in the game. There is no wrong door. We can start wherever we are with our unique perspective, skill set, and sphere of influence, and find partners with different perspectives and skill sets. Learn from each other and create a blueprint for moving forward. Use forums like these to learn from each other, connect with each other, and just get started. Today's focus is on benefit design, and don't get me wrong, we're under no illusion that that's a panacea. We're under no illusion that benefit design changes will fix the problem of health inequity. But it's one step that we can take, and it can help us move things in the right direction. So, how did the American Academy of Actuaries get involved in health equity? As Jennifer said, in spring of 2020, with the death of George Floyd, the entire country, as you know, became keenly aware of social issues, social justice issues in the US, and around that same time, although health equity had been identified as a public policy issue for decades, the disparate impact of COVID-19 on racial and ethnic minority communities brought health equity to the forefront of everyone's minds. It was with this backdrop that the Academy established the Health Equity Committee in 2020 so that we could use our actuarial expertise to help work towards solutions that would decrease health disparities. So, for those of you who are not familiar with the work of actuaries, I'll just take a minute to tell you what we do. It's still mystery to my husband, but I'll try. um, so, actuaries evaluate and quantify risk. We evaluate the likelihood of future events and mitigate the financial impact of undesirable events. Health actuaries, in particular, are trained in the financing and delivery of health benefits. So, health actuaries are involved in many aspects of the healthcare ecosystem, such as designing health benefit packages, developing premiums, designing provider payment models, performing data analytics and financial projections for employers, insurance companies, and governmental agencies. In other words, health actuaries are literally in the room working alongside other professionals and decision makers in many areas of the healthcare ecosystem, providing our quantitative and analytic perspective. So it kind of made sense for us to get involved in this conversation. Jennifer talked about the work of the Academy's Health Equity Committee, so I am not going to go into that. What I would say is I'd like to share with you some of the things that came into full focus for us as we started our journey looking at health equity. First of all data have bias. It's not a judgment, it's a fact. It is therefore important for us to recognize and identify the bias and determine whether it would skew our results based on how we were planning to use that data, and then find ways to adjust the data to mitigate that bias if needed. For historically marginalized communities, and this is a big one, this was a little bit of a surprise to us, claims data understate morbidity risk and unmet needs. So there's a lower correlation between cost and risk for those populations. Understanding this fact when projecting claims data is crucial to avoiding unintended consequences. And thirdly, using an equity lens changes how we see policies, laws, and regulations that we've become so used to and thought were unbiased. Again, it's not a judgment, just a fact. So it's important to be intentional about using an equity lens when proposing or reviewing new policies, laws, and regulation, because that's an opportunity to make a change. Yes. So for 2023, as Jennifer said, our focus at the Health Equity Committee has been on equity enhancing health benefit plans, such as value-based insurance design, or VBED, and benefits to address health-related social needs, such as non-emergency transportation and benefits to address food insecurity. Now, these types of innovative plan designs have been around for years. It's not new, but they haven't gotten much traction. So we decided to host a series of workshops with experts from different disciplines to explore the barriers to implementation of these innovative designs and hopefully come up with practical ways to overcome these barriers in the employer-sponsored health insurance market. So that brings us to today. This symposium is the culmination of those candid discussions as we seek to deepen and broaden the conversation to apply the insights gained from the employer-sponsored market to other markets. The lack of actionable data has been the one reason cited by many in the health equity policy space as the reason for the lack of progress on health equity. However, you can't fix what you don't measure. Working on improving health equity means setting up important infrastructure so that the improvement in health disparities can be measured and tracked over time. So when we talk about infrastructure, what are we talking about? Well, we're talking about creating a data repository to collect data that would be used to measure disparities in a consistent format, aggregated in one place with all the privacy protections and yet accessible to those who need it. It means creating a single framework for measuring disparities. It means creating a single repository of information and research on health equity, all nicely indexed, so that anyone could access it, even those without a PhD. It also means developing a blueprint for calculating return on value, which can be substituted for return on investment when measuring the efficacy of health equity programs and initiatives. Yes, there are people already working on these types of initiatives, but these are not simple tasks. Otherwise, they would already be completed. So the question is, what can we all do to move this forward? It goes without saying that measurement is not enough. We actually need to make changes that will improve health equity and reduce health disparities. So what will it take to achieve health equity and eliminate health disparities? I have the formula. It will take humility, courage, focus, collaboration, perseverance, and action. Humility. As the saying goes, humility is not thinking less of yourself, it is thinking of yourself less. Keep our eyes on what we're trying to accomplish. It's okay that we don't have all the answers. It's more important that we remain curious and ask the right questions. Courage. Have the courage to accept that we all have biases, to examine those biases and processes that may be contributing to the problem and interrupt or at least mitigate their potential negative impact. That's not easy. It's uncomfortable, and we need to find the courage to do it. Focus. Trying to solve health equity can be overwhelming. Each of us who touches the healthcare ecosystem has a part to play in finding workable solutions by focusing on our area of expertise. That's where we can have the biggest impact on disparities. For example, actuaries can focus on quantifying disparities. Collaboration. We can't do it alone. There's synergy in working together, and there's a lot to learn. Include others with different backgrounds and perspectives and break down those silos, because that's where the magic happens. Perseverance. This is a marathon, not a sprint. And every step forward counts. Even going backwards helps us to define the way forward. Action. Finally, the time to act is now. We can't wait for perfect data or the perfect time or the perfect evidence. We can start with what we have and make incremental progress. That said, we do need to be intentional and aware of the limitations and potential impact of the information we're using and be able to hit the pause button when needed. So here we are today to learn from each other, from our successes and our missteps, to continue our journey, focused on our strengths and areas of expertise, yet working together to solve a multifaceted problem that is bigger than ourselves. I sincerely hope that the discussions today will spark an idea or two or 10 that will help us move the needle on health equity. Now let's roll up our sleeves and get to work. Thank you very much.
All right, thank you, Annette. My name is Cori Uccello, and I'm the Senior Health Fellow at the American Academy of Actuaries. Joining me is Becky Sheppard, a member of our Health Equity Committee, and soon to be co-chair of the committee. We'll be tag teaming for our presentation. Our role is to give some context for today's symposium by providing a brief summary of the health equity workshops that we held earlier this year. We'll also preview how today's symposium sessions will broaden and build upon those conversations. Benefit design can be used as a tool to enhance equity. In particular, lowering or eliminating cost sharing can reduce financial barriers to care. Adding coverage for non-traditional benefits can help address health-related social needs. Thus far, however, adoption of these types of benefit changes has been incremental at best and focused primarily on cost-sharing changes. So the Academy's Health Equity Committee held a series of workshops to explore strategies to incorporate more equity-enhancing features in health plans. We brought together people with different roles and different perspectives to offer their insights in 4 areas. First, the process of benefits design decision-making and challenges to incorporating equity-enhancing design features. Second, how benefit changes are evaluated. Third, how to incorporate the voices of the people we're trying to serve in benefit design decision-making processes. And fourth, how to address implementation challenges. We developed issue briefs to discuss the key points raised in each workshop. And on your way in, you should have been able to pick up a summary of those briefs. And if you didn't, we'll have a break and you can go out and get it. So as a first step, our efforts have focused primarily on the large employer market, especially those who have self-funded plans. Not only does the employer market cover about half of all the country, employers can think more holistically about their benefits and may have more benefit flexibility. It's our hope that lessons learned in the employer market can help inform decisions in other markets as well. And today we'll be broadening our focus somewhat to think about implications for other markets. So this wasn't an exercise of actuaries just sitting around talking amongst ourselves, as fun as that can be. Instead, we knew, it's not that funny. Instead, we knew we had to hear from those who play other roles in the benefit design development and decision-making process. So we talked to a lot of different people. And now I will pass the baton to Becky, who will begin the overview of our workshop findings.
Thank you, Cori. So the purpose of our first workshop was really to set the stage for future discussions. We couldn't attempt to solve the problem if we didn't first understand what equity-enhancing benefits are being used today and why are they not more widely adopted. We learned a lot in that first conversation. We learned that healthcare disparity is complex. It doesn't just impact individuals who are covered by Medicaid. They could be covered by any type of insurance. There are many factors that contribute to the disparity, so simply changing a cost share might not be enough to resolve the underlying issue. And individuals are unique. They're made up of a lot of different characteristics, and so they can face disparity among many different dimensions. Employers and their workforces are also unique. There isn't a single solution that's going to resolve disparity across any type of workforce or any type of employer. Employers have to balance a lot of considerations. They need to think about strategic, legal, and financial implications of changing their benefits. And there is definitely a push and a focus on needing to reduce or manage costs, which we're going to talk about a lot more today. We also heard loud and clear that data is a key to being able to identify the need and design what solution might be best to address that need. Some of the common benefits that are used today would really address cost sharing like copays rather than offering a non-traditional benefit that might fill in the gap that the disparity has created. When those type of benefits are offered, they tend to be done through a pilot program so the employer can test out how it works before rolling it out to maybe a broader population. And one of the main keys to success is making sure that you not only have the benefit in place, but individuals know about it. If they don't know it exists or they don't know how to use it, it's basically ineffective. So that will bring us to our first panel discussion today, where we're going to hear firsthand from employers their perspective on this topic. They'll walk us through how they think about health equity, what lessons they've learned on their health equity journey, and how you can balance these differing priorities that each stakeholder has.
We should have planned this better. Okay, glasses down. Our second workshop explored in more detail how benefit design changes are evaluated and ways to overcome challenges in how current methods may constrain innovation. Perhaps not surprisingly, employers and insurers focus significantly on costs when determining whether to change or add a new benefit. To add a new benefit that would add costs, offsetting savings, especially in the short term, is usually needed to be identified in order to add that benefit. But there may be ways, and we hope to explore them today, to move beyond a short-term cost focus. Employers may be able to leverage their relationship with employees and consider the longer-term impacts of benefit changes, especially when they have longer tenured workers. They may also be able to use qualitative data to get a better sense of unmet needs and how plan participants prioritize meeting those needs. And ultimately, defining success in terms of cost effectiveness rather than simply costs can improve equity and also improve the use of healthcare dollars. Our second panel will get more into these issues, starting with talking about what do we mean when we use the term cost effectiveness. They'll also discuss how benefit design decisions are made and how new benefits are priced. And they'll discuss affordability, not only in terms of the employer, but also in terms of the plan participant.
For the third workshop, we want to focus on making sure that we also considered the voices of the people. We didn't want to just assume we knew what the problems were. We know that data is critical, as we've mentioned, but also data empathy is very important. We want to be thoughtful about the data that we're studying and understand that it represents people and their experiences. One way to do this is to really listen to what people have to say. We don't want to just assume that we know the solution or even that we know the problem. It's better to ask. But it can be difficult to really hear the response because we may have unconscious bias that makes it hard for us to really absorb what people are saying. We need to remember that one individual doesn't represent an entire group of people, and one group of people doesn't represent an individual. As we said, individuals are complex and they have various dimensions. Even asking may not be enough, because if our employees or individuals don't trust us, they're not going to share honest feedback. So we want to make sure that we can build that trust and that we can also maintain that trust by being honest and being transparent. One way to do that is to let your employees or individuals know how you're going to use the information that they're giving you as feedback. Providers can be a trusted advisor, and so one way to help get engagement of new programs or new benefits is to make sure that providers know how they work so they can help guide their patient through that new benefit. This brings us to today, where we're going to continue to build on this theme during our keynote address. We're thrilled to be able to have with us Dr. Lisa Fitzpatrick, who will be our keynote speaker. She's going to share firsthand her extensive experience in building trust and engaging the patient. Following her presentation, we'll have our third panel discussion. At this panel discussion, we'll continue to build on these themes, and they're going to talk about strategies we can use to help individuals understand the benefits they do have. How can we really collect that feedback that we need to understand where the unmet needs are and how we can address them? And then also the importance of using trusted messengers to relay that information to the individuals.
Our fourth and final workshop explored implementation challenges and broadened the focus a bit to also include insights on the individual and small group markets. Annette, you're going to hear common themes throughout the day, and one of those is the data we have are not perfect. They might be incomplete. They might not be comprehensive. But what we have is probably enough to identify some unmet needs and start the process of trying to address them. And at the same time, we can work to improve data collection efforts. Having a health equity champion in a leadership position can help make reducing health disparities a priority within the organization. Enhancing access and utilization of care goes beyond just what's covered and the cost sharing for those benefits. It requires having accessible providers, ideally those who speak the same language and understand cultural traditions. But too often, there's a lack of not only culturally competent providers, but too few providers more generally. Such shortages need to be addressed to improve access and health equity. And finally, cooperation from state and federal authorities may be needed to eliminate any regulatory barriers that may be inadvertently inhibiting health equity initiatives. Our fourth panel will discuss these issues, including how to improve data collection efforts, how to address provider shortages, and how to overcome regulatory challenges. And then we will have a fireside chat in which Annette James will talk to Dr. LaShawn McKeever. Dr. McKeever is the Chief Equity Officer at AHIP, and in one of her prior roles, she served as the Director of the CMS Office of Minority Health. Dr. McKeever will provide her insights on making health equity efforts sustainable, how to commit to systemic change, and the importance of achieving collaboration among other stakeholders and participants in the health ecosystem. So as you can see, we have a really exciting day planned. And now I'll turn it back to Becky, who will introduce our first panel.
Thank you. At this time, we'd like to invite our first panelist to the stage, where we're going to hear firsthand their employer perspective and what they've learned on the health equity journey. Jennifer Alexander, public health researcher and focus group moderator, will be moderating this panel. She'll be joined by Nathan Counts, Assistant Vice President of Total Rewards at Amtrak, Tammy Fennessy, Chief of Benefits at American Eagle Outfitters, and Dr. Christa-Marie Singleton, from the Chief Medical Officer from the U.S. Office of Personnel Management. Please welcome them to the stage.
I'm going to sit here. And so I know that one of our participants, Christa, may not be here yet. She is coming from a different conference. So when she arrives, we will include her, but that's just more focus on you two. So let's go ahead and get started. So first, by way of introduction, we're going to have both panelists give a kind of high-level overview of where they are on the continuum of health equity and using equity-based health benefit designs. The goal of this session is to hear from two, hopefully three, different representatives who have different workforces with different needs, different priorities, different challenges and opportunities. And we're going to hear about their journey, their challenges, and successes. So where is your organization with respect to health equity? How big of a priority is it? How big of a priority is reducing healthcare disparities when designing or changing benefits? And feel free to just jump in. Yeah, sure, Tammy.
Yeah, no, I'll start off here. So yeah, I'm the Director of Benefits at American Eagle Outfitters. So we're a large retailer. If you have any teenagers, they probably love us. At least we hope they do. But you know, we have a very geographically challenged population, very young in age. So a lot of them first time on health insurance. Also have distribution centers located in various locations where they've been identified as having food insecurity. And living in food deserts, living in hospital deserts, OBGYN deserts, pharmacy deserts. So it's definitely it's a big priority for our company. You know, because throughout the pandemic, as most of you know, distribution center employees did not stop working. You know, if anything, people started ordering online, and our company in particular, selling leggings and comfy clothes. We had a lot more online sales, and they actually had to ramp up their efforts tremendously. So we consider them to be the heartbeat of the company. So I think, you know, throughout the pandemic, you know, we definitely had our eyes wide open. But, you know, we've been, I think, treating this as a priority for quite a number of years, at least 5 to 6 years. And I think, you know, our leadership is very committed. They understand this is a priority, that organizational health is imperative and that requires a healthy population. So we want to make sure that we're investing in them and showing them that we care. And I think we've seen the effects of that. I think, you know, as an organization, when, you know, we went through the pandemic, we didn't cut off their benefits. You know, we furloughed and laid off 37,000 people. We didn't stop paying for their benefits, and we didn't charge them when they came back. And I think that meant a lot to our people. I think they truly understood at that point just how much we care. And it went a long way to build trust. And I think they, you know, they're in this with us, and they want to share, tell us what they need. So we talk to our ERGs a lot. We talk with leadership. We share back their, you know, their needs, their wants, their responses. And that's pretty much where we start building our business case for improvements, you know, as we go along.
Thank you, and welcome, Krista. All right, Nathan, you want to go next?
So Nathan Counts, lead total rewards for Amtrak, but was an actuary doing consulting before that, and led a lot of benefits functions at AT&T. So maybe have a little bit of a benefits and rewards view. You know, I'd say we're very early in our journey. I think at our most senior levels, I think with a lot of the cultural changes Annette mentioned, I think that's recognized, right, by employees, by your customers, by our board, right, to ensure we're caring for all individuals. But I think our approach has largely been broad and condition-based, right? So we're thinking about things like healthcare navigation for the LGBTQ community or persons of color. We're thinking about doula services for fertility and maternal health. And so most of our approaches to date have been more conditioned and targeted, but maybe not personalized, as I think Cori and others were calling out as opportunities to say not all populations are equal. Even within those groups, I think there's a key opportunity for how we connect and serve. I think while we do partner with employee resource groups, it can be on more the back end, right? So we might have diverse teams working on these solutions and ideas, but how do we move more of that diverse representation from business and stakeholders to that ideation side? Benefits, I think, always lacks for utilization, right? I think we could always want more utilization, but if we're designing these broad solutions against broad population sets, you know, it's no wonder maybe we're not getting utilization across the diverse spectrum. So even something as simple on the back end, right, of arming ourselves, arming our vendor partners with the data needed to segment and say, where is there underutilization in our LGBTQ groups or persons of color, I think are opportunities for us. So data collection, sharing with you all, and privacy. So very early in the journey, but I think there is already kind of tacit buy-in from the employees to the boards, and so I think it's a good start and position for where we are, but certainly more opportunity to make impactful action.
Thanks. Nathan, so a follow-up question. Why did Amtrak choose to prioritize this, you know, equity enhancing benefit designs? And what do you say to other employers who maybe haven't taken this step yet?
Yeah, I think, you know, don't let perfect be the enemy of the good, right? I think even the broad actions we were taking, a lot of them have been in the wealth space. So recognizing financial inequity and its impact on health equity, right? So we were rolling out financial counselors at all levels, so everyone can meet with a certified financial analyst, not just take a financial wellness quiz that they, you know, put on the shelf and never respond to. We're looking at student loan support, right? We know that disparately impacts women and people of color for generational wealth. And so we focused a little bit on the financial side, knowing it will probably have halo effects on the health side. So I would say yes, while there's always more to do and a more perfect solution out there, don't let perfect be the enemy of the good. I think take the opportunities to deliver value where you know there's going to be impact.
That's great. Thank you. Krista, welcome.
Hi there.
So we're talking about sort of a high-level overview of where you are on the continuum of health equity and of using equity-based health design, health benefit designs.
Sure. So, good morning and apologies for being late. This is actually, I'm being bookended on this topic because Tammy and I were both at the National Alliance of Healthcare Purchasers meeting that led up this week, and my session at 8 a.m. that I was presenting on was looking at innovation in this space and what are other employers doing, what are we thinking about it. And so then to come in, and then in between coming here, one of the things that I'm really honored to be now part of the Office of Personnel Management. So I'm not sure what you all know about my background, but I will be celebrating 17 years of federal service at the end of this month, and majority of those have been at the Centers for Disease Control and Prevention, back home in my native Atlanta. But that being said, having the opportunity now to impact a larger swath of the federal workforce was something I couldn't turn down. And in that space, coming to this agency, this director we have, she looks at it, I think, from a place of both hearts and minds, which I think she really does care, and she's looking at where can we be better. But then we also have a mandate hanging over our heads, which is a good mandate coming from our president in the executive orders. So when an executive order comes down that says that all the agencies need to better address health equity, racial inequity, we gotta jump. And so the good thing, though, with this particular director is that we're not just trying to check the box, so you see health equity in almost every other term, but actually what are we doing at? So the call I was listening to in the cab on crossing the river was our director is saying, we do employee surveys, like everyone. And so 84% of our workforce enrolls in the Federal Health and Employee Benefit Program. That's awesome. Most public employers are like, oh, that's awesome, that's cool. She's like, but what about those other 16? What might be going on with them? And could affordability be a concern? So that call on the way in here was a focus group of listening to employees who are all pinging, I can't afford it, I can't afford it. Yes, the federal government gives us 69 health plans which to choose, but if you can't afford it, and what am I giving up? And one person was saying, I'm a black woman, and I have fibroids, and so I have challenges with fertility, and that's great, you've got a fertility benefit, but I'm likely not going to be able to use it. So one of the things in hearing that information, our plans are now, we're shifting. That's the beauty of us being the employer. We can say, we write the pen. We want you 69 to write in your contracts more attention to maternal health access. So we started kind of going on the condition pathway. Maternal health access, gender affirming care. We started to go down obesity because we recognize these trends. But now the challenge becomes, now let me show the meat. And so the contract now, we put that in the language. So you as an employer can put that in the contract. We want to see these elements of it. But I think it's important, to your point, is to get the benefit design to have people that have the lived experience of the group where you're going. Sometimes I would offer that, and one of the persons said, are there any doctors or nurses who are writing these proposals and these contracts? Because they don't really understand. And so sometimes as we do this, empowering the team to take a step back and say, who are the people we're really serving? Because if you're trying to get utilization to make your case, but if you didn't design it with the people who are going to use it, and all of us in this very, very privileged world, we may not be able to understand that. And so I'm really honored because our team is now shifting. The other piece as an employer that I would submit you want to think about is reshifting almost the naming, but then the reality check. So we have a benefits office, and that benefits office is now shifting to benefits, wellness, although that wellness is likely going to shift to well-being, and the future of work. Because a good chunk of our workforce is going to walk out the door, not only this next election cycle, it's going to walk out the door in the next year and a half. So that's an equity issue to think about who's coming in, how do we attract, and how do we retain those people. And so that's some of the equity issues that we're looking at in our journey right now.
That's great. Thank you. Thank you. Anyone else want to weigh in on any aspect of this? Health disparities that can be experienced among many employee and dependent characteristics. Any other sort of key characteristics that you consider? And I heard, both Nathan and Christa talk about conditions, right? Any other characteristics that you consider?
Yeah, I think when we're looking at ours, we also look at whether they're non-exempt or exempt. We're looking at their income levels. We're looking at race and ethnicity. We're looking at the zip codes that they live in to try and see, where the disparities exist. I mean, it's pretty obvious when you start looking at the heat maps and you start, really digging into the data that does exist. I mean, we know where the bulk of our populations are accessing care. So when we're at least if we're looking at those that are going through the most volume, being able to start there and looking even at things like the community health needs assessments that nonprofit hospitals have to put together to see like what disparities are they seeing, because they have to do those every 3 years. So leveraging those types of data points, county health rankings is another spot that we dig and mine for information. And it's not something that we're getting from our brokers and consultants. That's not something that's coming to the table right now. It'd be beautiful if it did, but it's just not in those meetings. We're not having that type of discussion. The health insurance companies I think they have the capabilities of doing heat maps, but they're not taking it that far. And we need them to. We really do. I mean, most employers, I would venture to say, I'm probably, I don't know, maybe like in the 5% range of employers that digs into the data the way I do. That might be generous. So a lot of employers are scared to look at the data. They're scared of what they'll find. Their legal departments are like, what are you going to do if you find X, Y, and Z?
All right.
So I think, but I think we make a commitment, and we've got our board is committed to this, and they understand. And when we find something, it's our due diligence and our fiduciary responsibility to take action.
All right, Tammy, I would definitely agree with that. And I hear the term, well, we don't have the data, and my eyes roll back in my head as a former CDC person, because you do have it. And to your point now, especially now coming to OPM, and back in 2021 when I was with CDC, we tried to partner to better look at asking our 69 plans, do you do any sort of social needs screening? Do you have any sort of baseline assessment of do you have any sort of programming in place? And we saw maybe about 30-40% of them had started to link their benefits with their social programs, which is good, but we haven't really moved further with that. And so when a colleague tried to implement it again, our general counsel's like, well, you really shouldn't be looking at the zip codes, because then it looks like you're targeting people. But if you're giving out a benefit and then it's not being used, now what? So asking the question of knowing where your employees live, and we the employers know where our workforce lives. So it's not hard to see where people live here, and here. The majority of federal workers, I guess the number one cluster is here in the D.C. metro, D.C., Maryland, Virginia, probably West Virginia. Number 2 would be California. I think 3 is New York, 4 is Texas. But my home base back in Atlanta is number 5. So if you see where these heat maps are, then further go down into the zip codes to see where people are. So Tammy and I first met on a project that we did together when I was at CDC, looking at the social needs of the workforce. So a lot of employers will say, well, I get this social determinants thing, but it's way too far out there. I can't solve the community's problem. Okay. Yes, you can, but that's a different conversation. But you can look at the social needs. Your workers have needs. And so Tammy and I worked together along with 5 other employers to start to say, where could we be on this journey? And Tammy's our exemplar of one who's leaning in. So you start to look at the zip codes of where your employees live. And then you look at the community information, and it's all publicly available as to where are some of the conditions and behaviors in the community. And so, Tammy, you tell your story better than I am. You saw where there were health gaps in terms of people with transportation and pregnancy, and you're working to solve some of those. So you're an example of where an employer can drive public policy. Back home in Atlanta, if you're asking people to do this, you should do it yourself. So we just did a tiny little pilot. We looked at CDC employees who took a federal transit benefit. And we looked at those zip codes, and then we overlaid publicly available community data, the percentage of hypertension, diabetes, whatever, so we saw where they were living. But one of the basic social needs we looked at was internet access. And because that is now a social need. And we saw gap areas there. So if you're asking people to log onto their phones and they don't have that piece of it, or you're asking them to do telehealth, but yet you don't have broadband access, now you've created another barrier. And then we looked at the percentage or prevalence of healthcare providers in certain zip codes. And we saw in Atlanta, if you draw a circle and then you bisect it, most of the health issues are south of that line. So one would expect that will be a dearth of providers down there. We found one zip code where we had a clump of our employees that had really high, at least numbers of providers there, but they had the worst health outcomes. So now there's something going on here. And so you as the employer now can dig into that. So before I left, I handed that off to that group, and I said, I'm going to the other side, but let's look in that a little bit more. So you as an employer, if you see these gaps as to where your employees are living, where the providers that you hire within your contracts, and they're not using them, then that's an aha moment for you to start to maybe you need some different vendors. Maybe you need to start asking questions of your vendors, what's going on here?
That's great. Thank you. So before I get to sort of the next question or topic area, I want to make sure that everybody knows that we're going to have a few minutes for questions at the end. So if you have questions, hold on to them until the end, and we will be sure to try to get to them. All right, so I want to back up a little bit. Obviously, you know, Chris, you were mandated, right? But organizations take different paths to trying to improve health equity. I'd like to hear a little bit, and maybe Nathan, you can start us about why you got on the path in the first place, and about that journey. You know?
I think for Amtrak, but also for many companies, right? It's a business imperative. It's, you know, if you go back and look at your company's mission, right, the communities you serve, whether you're a not-for-profit health system, right, whether, you know, you were a telecommunications company serving, you know, city and rural areas, right, it's a business imperative, I think, for how you serve your customers, right, that you represent the customers that you're serving. And so I think that's true for probably most employers in the room. You know, I think in addition, from just a total rewards perspective, having that seat, if you looked at bonuses or incentive plans, what are the behaviors companies were trying to drive? You go back a number of years, it was probably mainly profit focused or return on invested capital, but you've seen those type of plans incorporate non-financial metrics, qualitative things, softer things like customer satisfaction. And I'd say there's a reason to that, because they believe those things create broader enterprise value, that profit isn't the only seeking, you know, motive that you should provide your employees. And I think in the health equity space, it's something, there's a similar corollary. If your boards or leaders are struggling with the hard data, although, you know, the data is there as we hear, that health equity drives some of that broader benefits value. So even if it's a little softer, if it's earlier in its stage, right, there's the recognition, I think, across corporations, and you can, I think, help point to, hey, what are you doing in your incentive plan? We're trying to do the same thing here in the benefits side to say, yes, it's early days, but driving health equity is going to drive cost savings, right? The corollary to me is benefits very cost focused, right? But health equity will help you get there. And so for our company, and I think many others, that's some of the evolution that we're seeing at the board level, as well as what just our employees and customers expect of us.
That's great, thank you. And we're going to talk a little bit about internal decision makers and kind of their priorities in a bit, but good. Thank you so much. Tammy, do you want to?
Sure, yeah.
Sure.
Well, I'll kind of take you on my personal journey, which you know, fed a lot of the discussions that, you know, I did end up having with our leaders in the organization. But I think our DE&I initiative started back in about 2017. But I've been heavily involved with the Pittsburgh Business Group on Health and the National Alliance of Healthcare Purchaser Coalitions, as Christa alluded to, who we were at that conference yesterday when she was there this morning. But that was a big part of my learning experience, was being in the Pittsburgh Business Group on Health. I remember in 2018, we all got a copy of the equity report for Pittsburgh, and that's where our headquarters is. And we found out very, very quickly that maternal and fetal mortality outcomes were abysmal in Pittsburgh. And we're like 96% of the country is better than us. That kind of bad, yeah. So it's cringeworthy. It's horrible, and that definitely got me even more interested in health equity. Then, of course, the pandemic happens. We're seeing the outcomes. We're watching marginalized communities, Black communities, Hispanic communities, just affected by this so much worse than white communities. Not being able to get their hands on vaccines, seeing health literacy go through the charts. I remember watching on TV, Luzerne County, which is where we have one of our distribution centers. The people there, the Dominican population, which literally is like 90% of our distribution center, if not more. And they're on TV saying, "You're not talking to us. You're not telling us what's happening." And I was just heartbroken. I'm like, wow, this is real. These things are happening. And of course, then George Floyd, others in the Black community, murdered, losing their lives. That was a huge culture change for our business in general. I think that's when things just downright got personal. And that was when especially our Black associates were like, "I need help. Like I can't go to work tomorrow. I need someone to talk to. I need to be able to talk about this in our meetings." And I think our leaders, there was a paradigm shift. Everyone was like, "Wow, we can't avoid personal conversations anymore. We have to be there in a different way." And I think that the uncomfortable conversations, the moments of broaching these other topics, really opened up. And I think it's just changed who we are altogether. I mean, we're just different now. I mean, we want to hear what our people have to say, and they know that we want to hear what they have to say. So that's why I think our ERG philosophy has grown so much, and it's become such an ingrained part of how we build up our benefit structure and everything, because they're not afraid to raise their hand and say, "This is a gap. I have a gap. I can't get coverage," or "You should be changing this. This isn't right." And then we look at it. We don't ignore it, and then we pass back the credit to them for bringing it up. And that's important to us too, because we want to just make sure they understand. Obviously, what Christa was saying in regards to leading by example, that project, it was amazing. It was amazing, yeah. And I mean, that's how we found out. We had 90% of our Hazleton distribution center speaking, non-English speaking. Over 90%. 11% of Dominicans are in Luzerne County. Over 90% are in our distribution center. We're the hub, we're the community. And that's a good feeling. We want to be there. That shows us it's a safe space, but we had to make it even safer, and figure out what they needed. So, yeah, if you can't tell, it's a passion project for me. I'm actually going for my, master's of science, my master's in population health management through Johns Hopkins because of this as well. It has put me in a completely different mindset.
Well, Tammy, what shows your leadership and your company's leadership, not only did you realize that it was the Dominican population, because I remember us having some back and forth, because during the pandemic, the pivot was, okay, we'll have something in English, and then we'll have something in Spanish. Well, there's different dialects within the Spanish language. And you had said, "Oh, wait, we asked Quest to just translate to Spanish," and I'm like, that doesn't fit.
No.
So now when you realize there's a different demographic, and then you went to those leaders in those communities and said, "What do you need?" And that's when they not only told you about the language barriers, but then the transportation issues that you went to solve. So it's understanding within those communities, and I think a key loop back is the report back, so you create that trust so that they will come. And then if they are you as an employer, we as employers have to be vulnerable to say we don't know. Then when the employees, we build that trust, they tell us what they need. Then we in turn have an obligation to refer it back. So even on this call this morning, the employees were asking, and I'm typing notes to my deputy. I'm like, we can't let off the hook here. We have to give them the results back and say, you told us these 10 things. Here's a gap area. Here's what we can address immediately right now. Here's what we need more time on. Because if you don't close the loop, then that trust moves away, because it really is a business imperative. Not only are we paying all these claims for individuals, we also are trying to retain this workforce. And now, to me, it's almost like a workers' market. You know, after the pandemic, you know, employees are saying, I may have other options. And so if they're not coming back into the workplace or not staying on board, then we have a retention issue. And so that movable middle is where I think this becomes an equity issue. And it's the business imperative to keep our employees.
That's great. Yeah, thank you. Yeah, and that feedback loop is so important. I'm glad you highlighted that. All right. So I want to talk a little bit about successes and challenges. It sounds like you've had some wins, you know, all three of you, as well as some challenges. And so I'd like you to feel free to brag about your biggest successes, but also kind of the challenges and what you've learned from those. So Nathan, why don't you start some?
Yeah, I think for us is really was capitalizing on this moment and sea change, right? You know, from an employer benefits perspective, I think you're viewed as a cost center, right? So a lot of time with the CFO, probably even more than the CHRO or the chief people officer, right? But there's been this moment that Tammy talked about where we recognize through COVID and everything happening, right, how much life impacts work and how much work impacts life, and now employees are empowered, right, to share that message. And so I think for us, it was capitalizing on some quick wins, right? What can we do now? And for us, that was a focus on some of the financial well-being. So while we worked to improve what was happening on the health side, whether that's data sharing or many other things, we felt like we could at least address some of the financial matters through financial counseling, through health savings account seeds to lower income workers, or, you know, through some of the student loan support, right, as people just struggle with what to do from a debt perspective. And for those public service companies, right, there's an opportunity for loan forgiveness. So really focused on solutions, too, that tried to not give people homework, not give people a list of things to do, but we're aimed at addressing the unique needs and saying, send that our way, and we will source and find vendors that, you know, are representative. You know, the people that answer the phone will have representation that looks like you. The network, right, and our contracts will ensure the providers will represent and look like you as well. Another positive for us was, you know, employee assistance plans. So, you know, while we think of that as, you know, where you go when you might need help and therapy, it's also kind of this legal construct or gray area where you can offer high-valued benefits to all your employees and their household. And so we kind of leaned into this idea that wherever we feel comfortable kind of EAP-izing a benefit offering, that's a vehicle to deliver, right, a no-cost benefit for you and anyone in your household, right, whether that's expert medical opinions or some of these concierge benefits to help address inequities. So those were areas of focus. Again, definitely still wrestling with just the basic of data collection, right? We have race and ethnicity data, but we're working through the self-identification so that we can have other lenses by which to view our offerings. How we share that downstream to our vendors, I think we're working through what's the privacy, right? We might want to share it with a vendor so they can help you, but maybe you don't want them outreaching to you in that way. So I think those are areas where we're still wrestling and have challenges, but again, I think there was a lot of good out of the gate where we knew there were opportunities and could try to push for quick wins.
That's great. Thank you. And have you considered or used changes in cost sharing at all, or value-based insurance design to increase the access to the care that's needed? Or
yeah, we have. So
talk a little bit about that. Yeah.
we provide essentially primary care co-payments if you visit a specialist. And that's not just driven by an insurance carrier network. That could be, hey, if you're going through a concierge that we believe has employees answering the phone and can guide you to a network, whether it's LGBTQ+, persons of color, will drop your co-payment, right? And so there has been incentives to kind of some of our concierge systems to say, just go through this practice. We'll help you get you to a network that's trusted for your community with a list of questions that's personalized to your community. So not just, maybe your traditional high-performance network, so to speak. But we've seen a lot of success with that, and we're a heavily unionized population, and even they, I think, understand and recognize the need for opportunities to deliver that value. But maybe the flip side, or just to underscore a comment made earlier, was wherever we can put something in the construct of that legal employee assistance program, which means no cost to the employee, and can be offered to members of their household without having to enroll in a benefit, that is also kind of an end-around opportunity for value-based design. So we're operating both within the health plan and then trying to add lots of support outside of the health plan, financial, legal, et cetera, that can drive and that we know impacts and correlates to decisions around healthcare.
Yeah, that's somewhat with us too. We've encouraged our carriers to really move toward or selecting centers of excellence where we can see better value, particularly on the area of maternal morbidity and mortality. And we really stressed this past year to have our carriers look at birthing-friendly designation hospitals so that you can see where the care is better identified. That's a plus. Of course, we all know that there's maternity deserts out there and access issues. And so that is a goal, and it's moving, but I think it's pushing that even further. Yes, you may, if that hospital doesn't have that designation or that care center doesn't have it, but what else is in that area that can give restructuring your payment so that you've got a collaborative team and paying for that piece of it as well. So that's the beginnings of that wins. But it is still a struggle. I think we need to kind of better understand what should be in that bundle and look for different models to find examples that the carriers can then latch onto.
Okay, thanks. And so how are benefit changes implemented, Christa? Are there pilot programs? Do you just sort of make incremental changes? How does that tend to work?
It tends to multiple ways. We look for, or we can find, evidence-based models. So we look to our colleagues in Baltimore at the Centers for Medicare and Medicaid Services in their Innovation Center. We see examples there because our population, we have the 20-year-olds to the annuitants, the retirees. So a lot of the projects out of CMMI are on the Medicare group, and so we'll lift from them to see examples, and then that becomes the evidence base then to put them in. So that's one set. We are starting to look for we also look at other large public sector employers to see what they have done. So we look a lot to California because I mentioned that they're a public sector group to plant those in. And then we look at industry trends. So we see what the private sector is doing. Probably not as much as I would like, but that's what you hired a new medical director to kind of do. Because you need to know. You don't know what you don't know. And to see where people are doing things. But to Tammy's point earlier about the kind of drumbeat about looking at social determinants and social needs. So we do have a lot of carriers that are starting to look at this question and not just identify are people having access to transportation or food or other components, but then how are you as a carrier linking that to that case management? And that's a piece that it was very encouraging to see a large number of them in 2021 at least starting to ask the question, and several of them in the smaller plans having resources. So we just sent out another nudge to them this summer where we reminded them that it's a priority. It's actually a benefit for you to better, I don't want to say target, but better focus your care if you know more about them. And we've started to foreshadow that there's other, again, hearts, minds, if you don't want to do it because of the right thing to do. There's some mandates coming down, and we go that way. So we point them to opportunities such as that over at NCQA. So they now have a social need and screening intervention measure that has a focus on identifying the need and then solving it for a community partner within 1 month. And so that's out there. NCQA also has this health equity recognition and accreditation. And so for a CFO, you might like that. Oh, we can say that we're a center of excellence here. So we're saying that's available to you. CMS now has a Medicare hospital the prospective payment system that's going to be requiring hospitals to report what portion of their population is screened and test positive for various SDOH categories. So when the money piece starts coming down and these plans are going to have to say, wait, my hospitals, are you paying this or not? That's going to put more attention on it. And to the data question, there's a national collaborative called the Gravity Project that's coming up with data standards, so that's going to be helping with these kind of these gentle nudge mandates with NCQA, CMS, that one, JCO, via the Joint Commission for Hospitals. They now have a measure and a mandate that's going to say, are you doing any kind of social needs screening? And then that's this year for that component. And then the next piece for the accreditation, did you fix it? So as carriers have to get contracts with these groups, I think it's going to start raising the question a little bit more.
I like the description of mandates as gentle nudges.
Yes.
Go ahead, Nathan.
I was just going to say for pilots, right, I think, actuaries, a lot of data minded, you might think, yes, a pilot would be great. You can do a cohort analysis, a small group, find some initial value. But I think oftentimes for employers and even for the vendor partners we leverage, contracting can be such a challenge. And so it's really as much work to pilot as just to roll it out to a broader population. So pilots can be, sound good in theory or principle, but in reality, I think can be very challenging for ultimately for employers. So just as maybe a recognition in this space, I think sometimes something that works similarly is you might have some of your colleagues in HR, finance, wherever, demo or trial a product, get some feedback to validate maybe what you expect a return on investment to be. But
I'm so glad you said that. I even have
Go
the
ahead,
note on
Tammy.
here where it's like, pilot solutions. My experience, it depends. Not easy usually.
Right.
Okay.
It's the same thing. Yeah, you need the contract in place. If it's going to be something where you're sharing PII and PHI, then you have to get your IT security questionnaire in place and everything else. So, I mean, you've got all the players there. So it's really hard to invest that amount of time and energy into a pilot, especially when it's healthcare related.
Yeah,
For sure.
that's helpful. Thanks. Yeah, that's interesting because you would think a pilot sounds great,
Yeah.
right?
Sure,
You always want to
yeah.
test these things out, but that's good to know that comes with sort of these unforeseen challenges.
So,
Mhm.
I would just say, so we have over 40 point solutions at American Eagle, and half of those were implemented between 2019 and present.
wow.
So, so there's a lot, and there's a lot, to these, point solutions, and trying to figure out the ROI and what, is it really worth it? But at the same time, we're trying to meet, our associates where they are, and we want to make sure that we're showing up in spaces where they've, expressed to us that they have a need. So we're not looking for everyone to go gangbusters on utilization of these, but we also want, we want to help the silent sufferers. We want to be there, like in the fertility space. We want to be there for, chronic condition management or getting, digital musculoskeletal, programs in place to keep people hopefully out of surgery. And I think if I can address one other thing just in regards to the previous question, some of the things that we have done that I think have been really successful is, and it came right out of actually the Leading by Example project. We had all of the reinforcement in the world to open up healthcare centers in our distribution centers, and that's made a big impact, and not only just for people to get non-acute care at no cost, whether they're on our medical or not, but also we set up separate ones in the same locations that are strictly around workers' compensation and making sure that they're following their PT regimen and stuff like that. So I think it has really helped us to control a lot of the costs that are out there.
Interesting. That's great. So going back to the point solutions.
Yeah.
Positive, negative, are there just too many? You said, 40?
So we've actually partnered with a vendor where it's a care navigation solution.
Okay.
So I think that's helped us a lot. And people do know that it's a one-stop shop. We had about 7 different places that people would go originally to find out information, and we shut them all down and said, okay, you have one. Download this app, or go to this space, and we set it up with single sign-on to make it super easy for them to get in. but they have care navigators, so we have high-tech, high-touch solutions, which I think is important. People want to be able to talk to somebody if they need to, and if they don't, if they just want to, if they're savvy and want to get out there and just search on their own, they can do that too. But our care guides have been very, very helpful. They get trained every 3 to 6 months on every benefit we have and any changes that we have. So they have, resource documents, they do the soft transfers, and they help people. So they're kind of like another arm of our benefits team. So
We went down that pathway on the area of caregivers because feedback came up when you were looking at what are the challenges of your workforce in that sandwich generation of individuals. Like I myself, I have a 17-year-old back in Atlanta, and I've got an 88-year-old back in Atlanta, and mom travels twice a week. So it's like, how do you work this through? And so that feedback came across for our group, and so we too have a care navigation component specifically for caregiving, and a lot of focus each month on opportunities for caregiver support, not only a safe space for people to talk and work through whatever, and sometimes, they crowdsource amongst themselves, but then also additional solutions for, the child, the senior, navigating through all of those elements. So that's another way to help, because there's so many confusing points in that. When you're taking care of a senior, I'm not sure which is challenging, more the teenager or the senior, but they often have similar places. But and so because you're trying to work and navigate the health system and navigate being an advocate for your family member, it's a lot. So having that caregiver point solution, that's something that's been helpful. So I've gotten good feedback on that one.
Yeah, interesting things.
Yeah, I think there's been a lot of, point solution fatigue, both on the employer side and employee side, right? It's too many points of entry, even if it was very well intentioned. And so I think you're seeing, whether it's the investment community or employers, right, that marketplace swing back. And I think the point solutions that have remained sticky, right, are the things people maybe are more naturally inclined to want. So whether it's care navigation, family building support, right, but more challenges on diabetes care. Okay, I don't need a coach to tell me to, take my blood glucose each day, right? That or to excess weight, right? To eat better, to exercise more. That's not helping me, and so I think in those spaces you're seeing more consolidation and swing back to more network or ownership of primary care. And I think it's overlay to health equity might be, well, I'm going to partner with a primary care group or have an on-site clinic where, again, the staff isn't just trained to have sensitivities around equity. They are representative of the community by which they're serving. And that's where I'm going to see changes in A1C and diabetes. That's where I'm going to see changes in excess weight. So I do think you are seeing a big retrenchment. And even the largest of largest employers in the U.S., right, I think are struggling. So if you look at a middle or even large size employees, I think they're looking to try to purchase a more holistic solution versus, fertility and menopause, transition back to the workplace, right? Employers are trying to look for a bundled solution, and so I think you've seen the market react to more aggregation in this space. So there's less points of entry into the system. But
Thanks. Yep, does sound like that. That's the way it's going. All right. So we talked about this a little bit, but I want to shift to talking about internal decision makers. So obviously there are different priorities for different decision makers. The CFO's priorities probably differ from those of the benefits director. And so how are the priorities of the different decision makers? How do those get considered? How are they balanced? Talk a little bit about that. Go for it.
Go
Yep.
for it again. Okay. Yeah. So I think, from my perspective, the way that I always address this, every year, obviously, we go through our organizational values and our key priorities, and I take those to heart. I work with my team to make sure that whatever we're working on is feeding those organizational goals. So like coming into this year, we know that mental health is a topic that we definitely want to focus on and we want to double down on, and figure out how we can support our population. We know that workforce development is another area that we want to really lean into, so that our teams can have more meaningful work relationships and see a path forward, and and be given the support that they need to do that. So I think and year over year, that's kind of been the goal, is just to as each of, I mean, every year it's a different priority, but we know that people are our number one resource. Our associates matter. And I think, as they talk about, the priorities, I bring them right up to our CHRO, our SVP of Total Rewards, as well as our CFO, and say, this is what I'm thinking. Am I on the right path?
And how do you get them to consider other factors other than cost, which I think we all would assume that would kind of come first in some cases?
I think I think it goes back to what they're hearing from the field. If they're hearing from the field that, psychological safety is an issue.
So they're hearing it?
Yes.
Okay.
Then, if I'm coming back to them and saying, okay, how can we lean into that and best support you? These are the things that I'm looking at. Then it isn't about, about the cost at that point. It's more about how can we fix this issue? How can we be better as an organization? I mean, there definitely are moments, with other types of, programs where, I mean, you have to get rid of, certain point solutions or certain benefits, so you've got the budget for it, and that is a reality for sure. But I mean, I think that's because we're weighing it out. We're looking at the point solutions that aren't delivering, or they're not being transparent, not showing us what we believe is a true ROI. Coming to us and trying to, say we saved you all this money and it's in productivity, trust us. And we're like, yeah, no, we're not going to trust you. We want it linked back to our medical claims, and we want to see reduction. We want to see better percentages. We want to see better outcomes. So, yeah. So, I mean, I think there's a balance there.
Yeah. So, Christa, obviously there are different decision makers,
Yes.
but talk a little bit about
Sure,
kind
I
of the
was just
priorities and how you balance that.
Sure. So just on my team, we have 4 of them, actually. We have the contracting team that tends to look at the financial side, our actuarial team, our policy team, which tends to have was heavily lawyer-based. And then there's this tiny team of the medical people. Actually, I.e. one. But also the next one over is the pharmacy team. And so the common comment that comes across is, what about the cost, right? And so the retort and the answer that comes now is coming from both the medical side of the house, and now we're starting to get traction. You're going to spend the money anyway. The question is, do you want to spend it smarter? So that becomes a lot of the active dialogue. You're going to spend smarter. So in the rush, for example, right now on obesity drugs, the hot topic now are these GLP-1s. And so the immediate conversation, oh, well, that drove up our spend. Actually, your spend went up because of pharmaceutical drug costs overall. Just don't get hooked by the okie doke here with this tiny little object. Yes, that is an issue, but are there ways that we could maybe readjust and think through our benefit, the pharmacy benefit? So that's an active dialogue right now, is look at this total package, and that's another component of it. And oh, by the way, this GLP-1 uptick could be also to a better recognition of persons with diabetes, where these are helpful, and so maybe that's a piece. So now it's the people screaming about costs, those financial people, is you want the spend to come down, but you want it to spread out in a way that's a smarter space. So that's how we have that conversation to get them into the room. The legal team, we're not trying to get sued, and they'll pull up, oh, we had this case, and then because when the case happened, and then we the government lost the case, and then we had to pay out. So back into it. Maybe it was our contracting issue that caused that issue. So how do we clean up that issue? So that's how we bring this. So the legal people are constantly talking. So that's another voice to bring into the space. And then the workforce team that needs to come to the table, because again, we're trying to retain our workers, and so we think about benefits that way. But it's an active dialogue about cost. When we went down the fertility pathway, and okay, well, now we're going to be leaning into paying for IVF care, and the trigger was decided before I got there, but it is what it is, and I'm okay with it to an extent, about IVF drugs, and that's important. But now we're realizing it's not just the drug, it's everything else that goes along with it. And so now it's rethinking that perception. So great, we're being a leader in the fertility space and getting people access to this element if that's what they need for their life situation. But how do we spend smarter in that space? So
that's great, thank you. So Nathan, how about your sort of decision makers, or what's
Yeah.
been your experience?
It's, it might be stating the obvious and not always something you can easily impact, but, I think some of it starts with just your leader's own diversity, right? What are the teams you're building at that level that is representative of your employees? And what is their involvement already into equitable, right? Are they, we require our executives and senior leaders to be part of, right, employee resource groups, to be champions. So there's already, not just taking the moment, but we're already getting some understanding, right, that they have more solid belief, whether it's from themselves or their interactions with our employees. But I do think the most impactful are the moments that matter, right? It's the employee survey and engagement data. I think most or many companies might say we're unique, right? And for different reasons, even on the stage, right? We're unique. And so the market data can ring a little hollow. It's important, right? You need to have your facts there. But what really, I think, pushes it on those decision making is when it comes to life from the employees themselves, because inflation might be down, but we're still in a very competitive environment. Our company in particular, right, lots of growth mode, so attracting the right employees, retaining those employees, I think does ring true when they see, hey, 5 of the top 10 comments in our engagement survey might be around reaching out to the center around leave benefits or not being able to understand or access care. And so that's where we found more firm footing than just leveraging market data or putting maybe cost ROI information on the table.
Thank you. All right, so I want to make sure that we leave enough time for questions. So we're going to go to that, both virtual and in the room questions. And I think there is someone with a microphone.
We have,
there.
We
There you
have
go.
2 people with a microphone. If you have a question, just raise your hand, and we will bring a mic over to you.
Hi. Excuse me. My name is Simeon Niles. I'm with Morgan Health. I have 2 questions for Nathan, but I'm only going to ask one. I'll follow up with you on the second one. So you and some others on the panel have made comments about sort of the value of pilots versus just scaling more broadly. It's something that we at Morgan Health often sort of grapple with when we partner with our benefits colleagues. And there's sort of this balancing that we're constantly doing, right? We want to understand beyond just sort of uptake of a particular point solution. We also understand, are there other outcomes present besides just do the employees like it? And then also, like, once you deploy something, we're national, it's really hard to take it away. And so sometimes pilots, even though they are almost as much work as deploying it nationally, sometimes they offer us that opportunity to figure out, beyond what the salespeople tell us, whether or not this is going to be a real value add for our, 300,000 plus employees. How do you all balance that in your portfolios?
Well, I'll start with one. Again, the pilots are challenging, especially when you've got federal workers all over the place. But one of the things we do employ is we put in our carrier letter or call letter, which is our guidance to them. We will put something out like that and encourage carriers to put this in their own networks or their own benefit proposals, and then give them the resources and the justification for why. And oftentimes, some of our smaller regional carriers will try something, they will become the pilot. And then they come back and we can highlight them, so once one takes it, then the others will follow. So sometimes that's an opportunity for us. We encourage it for the carriers, so that's something an employer, if you've got multiples, put it out there, and if one takes it, then it can spill over to others.
And maybe nothing magical, but I think, when you're managing 40 vendors, sometimes, keeping what you're asking for them to do simple and, more uniform across the board. So, utilization, satisfaction, one value on investment metric, some short-term, item of return, whether that's ER visits, et cetera, and then a longer measure of return on investment, right? I think some of that simplifying in the contract. Data rights, right? You're probably have access to your own data and are building an ROI or business case based on what they say, right? But ensuring you can get the data so that you're just not going to get a report, you know, a year later that says a 4-to-1 ROI, I think is, you know, is critical in that. And so those have been some ways. And, you know, you're a more sophisticated buyer, but I think meeting with other employers, right, who are doing that purchasing, you'll be able to get a smell test from reference clients on some of that value of the product as well,
Thank
and
you.
where there are challenges.
So I think there was a question over on the other side of the room. Yep.
Hi, good morning. Lisa Fitzpatrick, Grapevine Health. My question is for Dr. Singleton and anyone else who has a response. You mentioned you get pushback when you talk about using zip code and neighborhood level data to really understand what's going on. I often use zip code as a reason we don't need to continue collecting data, but I haven't had people push back on that. So can you talk more about that? Because I think it's really important for us to realize we're missing the opportunity by not paying attention to zip code and neighborhood.
Exactly, and I would offer the pushback. I was surprised when we got the pushback from our legal counsel. And I think their interpretation, everything matters with context. And I suspect in reading, whoever presented it, the concept to them, did not give that context. As to here, it actually matters in the importance of better focusing that information. So that's why you need the zip code. You need to know where the patterns are, because if you're just handing out something across the board and you have variable uptake, that doesn't help you refocus your pieces of it. And so the attorneys saw it as a potential option for discrimination, that some groups would be excluded than others. But I think if you interpret it, maybe reframe it as, we need this information to see where the uptake is, how to better structure it, how to spend smarter, then that argument has been much better realized as one to then help us move forward.
Thanks. I think there's a virtual question. Yep.
Yes, we have
Sorry.
a question from our virtual audience. So they note that there's a mental health crisis affecting young adults and that affordability and access are huge barriers. They're wondering if you have reconsidered any of your mental health benefits as part of that, or if any initiatives or programs you have.
Yeah, back in, was it May of 21, I think it was, we put in mental health benefits globally for all of our associates. And they can also have up to 2 family members or friends access the same benefits. And we also did probably something similar to you, Nathan, where we increased our EAP, the Employee Assistance Program, sessions from 5 to 10 sessions per issue for anyone in the household, obviously, again, at no cost to them. And we reintroduced that. We're actually doing even more in that space going into 2024 to double down on it, because we know that, you know, there is a mental health crisis. There's a lot of people that have left the brick and mortar. And EAPs traditionally give people a list of, you know, folks to go to, and then you're pretty much dialing for a doctor. And, you know, and in this day and age, they're not answering, or they're booked, and you're not going to get an appointment right away. So we're changing our methodology starting January 1st to actually have like an advocacy model where they will reach out to the EAP, they'll connect with a concierge who will make the calls for them. Because I think that's the hardest step. You know, if you're there and you're finally taking that step to access care and you can't find it, we don't want people going down that hole.
Yeah, we've leaned into that one heavily as well, as part of the feedback from not only the focus groups, but the individuals who are coming to our employee benefits side, not the health insurance side. We're saying that's it. So there's been a lot more work being put out in the virtual space to help people for resources. On the health insurance side, the lean in was to really stress the collaborative care model, so that the gentle nudge to the carriers to have both primary care access and supporting your primary care providers to maybe help take some of this work off. Now the challenge, the devil's in that details, is because you need to pay your primary care providers to do this work as well. So that's an element of it. We have then queried the carriers to, again, give us more, as the young people say, the receipts as to who's in your network. Are you having ghost networks? What's the time to get people there? How many of you are using that? So we're asking a lot more questions on this, and I suspect it's going to be a stronger focus for the upcoming years, because the gap areas of not just, you can't just spit out a psychiatrist. So my colleague who asked the question about the zip codes, you're a physician, I'm a physician. It takes about 20 years to grow one of us. So you can't just expect psychiatrists, they're not the only space. And so we've challenged our carriers to say broaden the options, include licensed clinical social workers, include other types of practitioners that can help serve this need, because we need more support in that space, and we're challenging you to do so.
Thank you. Yep, go ahead, Nathan, wrap us
Yeah,
up.
just a quick wrapper on that. I'd say yes to everything they mentioned, but also some of that supportive tissue around those needs. So, right, we looked at changing our leave and time off policies, right? So, caregiver leave, whether you're caring for yourself, the sandwich generation, right? Some of the financial instruments around there, and there are, some dedicated preferred networks, right, for child mental health, that I think you can look at expanding too. But for us, some of the reasons that we're causing that stress might just be the time to care for those needs. And so by broadening, going a little bigger on time off in our leave policies, that was an adaptation I think we made in recognition of just all of the difficulties in balancing work and life.
Great question. Yeah, thank you. Well, so that's all we have time for. I want to thank the kickoff panel for your valuable insights. You've given us a lot to think about. Yes, absolutely. So we're going to have a short break until 10:50, and then we'll come back with our second panel session.